Well, hello everyone. Thank you so much for joining us for today's webinar. Today's presentation is called The Ins and Outs of Medication-Assisted Treatment and Recovery for Alcohol Dependence. My name is Misty Story, and I am the Director of Training for NADAC, the Association for Addiction Professionals. Today I'm flipping roles a bit and will not only be your organizer, but also your presenter. So I am really happy to have the opportunity to bring forward this education and address this important topic in this way. It's one of my passions and something I've been working on for the past 10 years with NADAC, so I'm really excited about this opportunity. So let's go ahead and dive into some housekeeping items here. The tool we are using today is called GoToWebinar. And the GoToWebinar control panel that you see on the right of your screen can be minimized and expanded by pressing the orange arrow. Doing this will allow you to see your whole screen during the presentation, but you can always reopen it by pressing that orange arrow again. Just so you know, this presentation is being recorded and will be posted on our website for later free viewing. I'll just send you a link to this recording later today if everything goes as planned, so keep your fingers crossed. If you're using your computer speakers to listen in today and are having trouble getting the volume higher, I recommend switching to a telephone line. We do not have any control over the volume output, but this switch seems to solve most of your problems. You should also know that all attendees for the live broadcast have entered in listen-only mode. This means that your microphones are muted, so we will not be able to hear you during the presentation. However, you have the ability to send questions to our staff or to myself through the questions pane during the presentation. To do this, you simply type in your question and click send. Due to time restraints, we will not be able to answer your questions live during the presentation, but we will collect your questions and post answers on our website. Behind the controls today, we have Tracy McPherson from NORC helping to answer your questions and providing support, so thank you so much for that, Tracy. And then also during this presentation, you'll be asked to participate in some audience polling questions. So to respond, simply click on the answer of your choice that pops up on your screen. I've got several of these planned for our presentation today, and we're not going to spend too much time on each one because I've got a lot of content that I want to get through as well. So try to be ready to answer those questions as quickly as possible so we can keep moving. And then also the PowerPoint presentation is available for download right now. I've tried really hard to make it so a lot of the content that I'm saying out loud is physically on your slides. So you'll be able to use this slide deck as a resource for later on when you need to go back and remember some of the nitty-gritty details that I go over. But my best wish for you today is to simply sit back and relax and try to just absorb the overall concept of what I'm talking about. It's quite a transformational process that can happen from start to finish to discuss medication-assisted treatment and recovery. And I don't want you to get bogged down on taking notes or getting lost in some of the technical lingo that I'm using. And just know that it's all there in your notes, and there shouldn't be anything that you need to write down unless you want to bold or star something in particular for yourself. Otherwise, let's just sit back and try to absorb it a little bit. Today's webinar is hosted and produced by NADAC, the Association for Addiction Professionals, and it was done in partnership with the National Expert ATTC, NORC at the University of Chicago, and the BIG Initiative. So we are so proud to have these collaborators with us today to bring this important education forward. And the education delivered today is free to all professionals. As you know, you do not have to pay to attend. And if you wish to receive CE credit for participating, you must pass the online CE quiz that's located at the web address that's on your screen. 1.5 CEs are free to NADAC members who participate in this webinar. Non-members of NADAC receive 1.5 CEs for $20, and this includes everybody. Those who are logged in today for the live event, as well as those who have downloaded the archive version. Either way, you are eligible to receive CE credit for participating in this webinar. Just so you know, this webinar is approved by NADAC and NBCC and NASW and OASIS in New York, and is accredited by the American Probation and Parole Association. So I hope that that gives you some options to be able to use this education towards your licensure certification. And then after you pass this online CE quiz, a certificate of completion will be emailed to you within 21 days of submission, although we try very hard to make that much quicker. So just to be super crystal clear out there, successfully passing the CE quiz is the only way to receive a CE certificate. And I don't think I finished my last sentence when I was talking about the PowerPoint slides. Those are up on the website right now. If you're attending live right now, you'll be able to click on the link that's in the chat feature right now that takes you directly to all of the materials related to this presentation, including all the recorded links as well as the PowerPoints and payment information, the CD quiz, all of it's up there now, so you can go ahead and find that pretty quickly. So I don't want to bore you with my short bio, and I'd rather use this time to deliver some of the rich content that I have planned today. So if you want to know more about me, like I said, I'm the Director of Training and Professional Development for NADAC. It's on that same website that houses all of the other information. So if it's okay with you, I'm going to just go ahead and dive right in, because I think that's what we're really here for. So the first thing that we're going to do is just talk about some pharmacotherapies and the myths around pharmacotherapies. Just right off the bat, I want you to know that what you're going to get today is hopefully some useful and unbiased information concerning the pharmacotherapies, also known as medication-assisted treatment. So you and your patients and your clients are afforded the best available resources and the options for their treatment. We want to look at some of the good things and the not so good aspects of treating alcohol dependence with pharmacotherapies, and just really give you just a snapshot of what is available, how does it work, and which clients would be most appropriate for this. And you're going to hear me say in the next hour and a half all day long that these are not appropriate for everyone. There is not one magic bullet. This is not a salve or a solve for anything. It has to be used in conjunction with biopsychosocial spiritual treatment all the way across the board. And this is just to really help you know what type of tools can be added to your toolbox, so you have other options to present when we know that we're presenting this menu of options, whether it be if you are a physician, or if you're perhaps a nurse in an ER or a hospital, or maybe you're a addiction professional in private practice, or perhaps you're providing the expert protocol, for example, and you want to provide some options that might help that client or that patient move further towards making a change with their problematic drinking. Having this information in that toolbox, I think, will better equip you to have those conversations no matter where you fall on the spectrum. So let's go ahead and just dive into our first myth that we have. Number one, the biggest one that I hear is medications are not a part of treatment. Not only are medications a part of treatment, there are 4 pharmacotherapies for alcohol dependence that are FDA approved. And as we said, they're not completely treatment by themselves. They are only one part, but they are one very important part to be used in conjunction with the psychosocial, educational, spiritual therapy. And now is the time for counselors and nurses and hospital administrators and everyone that is involved in client and patient care to educate themselves, to make sure that we're providing the best evidence-based practices available to patients. Because the reality is patients are aware of these medications now. They're being distributed in high volume, and so they're getting ads on television, they're hearing ads on the radio, they're reading things about them, and it's up to you now to make sure that you know what your patients know about the things they're coming to you about. And now the time is one of them they're going to be wanting to discuss is pharmacotherapy. So it's on you now to become educated about this topic. Maybe another myth that you've heard is that medications are drugs and you can't be clean if you're taking anything. I'm sure if we were in a face-to-face training right now, we'd have a lot of nodding heads and a lot of hands raised at this point. I'm sure this is something that you've heard before. And to that I say, right now is the time that we must embrace the current terminology, which is that medications are medications. These pharmacotherapies are not drugs, because drugs are illicit psychoactive substances that are used to achieve a high. And as we know, medications are available by prescription only and are used to treat an illness, a disorder, and a disease. And we know that alcohol dependence is a disease that has been widely accepted now in the literature and the research. And so it makes a lot of sense that we would switch to our terminology, and it's on all of us now as practitioners and in the medical profession to make this conscious switch. So when you're discussing medications, you use appropriately the word medication and don't toss in there a confusing phrase such as drugs. And we know that medications have been used to treat every single disease and disorder that's out there, including alcohol dependence. We've been using medications to help with alcohol dependence in the early stages for a very long time. For example, in detoxification. There's lots of medications that individuals that are going through the detox process are routinely given. So that's one of the first phases of alcohol dependence. And now we're discussing the treatment process and then further into the recovery phases of alcohol dependence and recovery. And then just to further the point, millions of Americans have been using things like the patch and inhalers and Zyban to quit smoking. Zyban is a medication. The patch is a nicotine replacement therapy that's just like opioid replacement therapy. We're essentially putting that same substance into your body to stave off any withdrawal symptoms. That's been happening for a long time, and this practice is widely encouraged by addiction professionals. So again, we're just trying to expand our current understanding and the social norms regarding these medications and show that it's something that we've been doing for a while. So moving on to myth number 3, medications are a crutch. I love this part of the program because this is something that I think that every single listener out there needs to be really aware of and might be surprised by. So here's the fact. The single most accurate predictor of successful treatment outcome is the length of time in treatment. I want to say that again because it's really important. The single most accurate predictor of successful treatment outcome is the length of time in treatment. That's not saying that it's the practitioner that you're working with, or perhaps maybe the medications that are coming involved, or maybe it's even the type of therapy that client is using, or a 30 or a 60 or a 90-day inpatient or outpatient treatment program. It's literally just saying the length of time in treatment. The longer that you can engage a client in treatment, the more successful outcome that they're likely going to have. And here's the fact. Pharmacotherapies are a way to engage in treatment, and they can help patients remain in treatment longer. They can help them continue to stay committed to meeting their treatment goals, and they can help maintain long-term sobriety. So just make sure that you're aware of that. Pharmacotherapies, again, are one tool in that toolbox that you have at your disposal to help make sure that your clients and patients are staying engaged in treatment and have the best possible chance of a successful treatment outcome by having the longer length of treatment available to them. We also know that modern science has identified several changes that take place in an alcohol dependent's brain. We know that these changes do not instantaneously correct themselves after a patient stops drinking. It can take up to a year for some of the changes that I'm going to discuss in this program to reverse themselves in the brain. And that's after someone has been sober for 12 months. There are still changes that are taking place in the brain that are trying to work to correct themselves. And so medications are not a crutch for that type of change. It's actually just providing support and acknowledgement of a real biological shift that has happened within the brain that needs to be acknowledged and a part of that treatment plan as the patient moves forward. And just to make the point a little clearer, all of these pharmacotherapies that I'm going to discuss have gone through extensive clinical trials. All of them were shown to be effective. I don't want to mislead you. None of them were shown to be 100% effective by any means, but they certainly were shown to be statistically significant when compared to placebo, that they were able to help maintain themselves in treatment longer, help stay abstinent longer. They're reducing drinking days drastically. Some of them help stay committed to meeting their treatment goals, as I mentioned before, and really are a part of the whole treatment milieu to make sure that someone can stay in long-term sobriety. But again, as you're going to hear me say over and over and over again, these have to be used in conjunction with psychosocial, educational, spiritual therapy. That's the only way that they have been proven to be effective. Moving on to this fourth myth, medications will get you high. Again, I think this is one that we've commonly put into our understanding of pharmacotherapies, and the fact of the matter is none of them that we're talking about today to treat alcohol dependence in any way cause euphoria, not even if they're combined with alcohol. So in other words, none of these 4 medications that we're talking about for alcohol dependence have any street value. In fact, naltrexone blocks the pleasurable effects from drinking alcohol, and disulfiram causes a severe physical reaction when combined with alcohol. So that's kind of the opposite of what conventional knowledge has told us about when taking medications to treat addiction, that they're going to get you high or they're addictive. This is perhaps stemming from some of the history of overprescribing and mismanagement of certain medications, and those most likely are speaking to the ones that are regarding opioid dependence. And those are some of them are addictive, some of them are opioid replacement therapies, and some of them do get you high. That is a fact. And if you're interested in that topic, next month NADAC is producing another webinar just like this one to talk about the ins and outs of opioid dependence and the medications that are used to help treat that. So we'll pause for that until the end of the presentation. I'll tell you some more about that. But let's get back to our discussion here with alcohol dependence. So again, none of them in any way are producing euphoria in any capacity, and quite honestly are doing the exact opposite in some cases. So maybe you've also heard this fifth myth, which is Alcoholics Anonymous says not to use medications. This is, again, one of those things that has just been brought forward in popular belief. And the fact is, neither Alcoholics Anonymous literature or any of its founding members spoke against using medications as a component of a recovery plan for alcohol dependence. This is something that was really held by leaders of specific chapters, and then it was spread erroneously to be AA doctrine. There is not one single bit of literature that you can find. It's not in the big book. It's not on their website. It's not in their pamphlets. They actually have pamphlets that are directly speaking against the practices of discouraging participants in AA to get off all medications, or they're not allowed to participate in the meetings if they are on any medication. This is simply not the stance of AA. Never has been, never will be, and they have lots of literature speaking against that. So they absolutely do not endorse anybody getting off of the prescribed medications or just continuing using those prescribed medications. They strictly do not adhere to that. That's something that's been falsely spread. So that's some big myths about medication-assisted treatment for alcohol dependence. And so that's kind of starting with some nice facts about it, but let's get to reality. There are some not so good things about using medications to treat alcohol dependence, and I think that I would be remiss if I didn't bring those forward for you as well. So let's dive into those. Fact of the matter, medications are not appropriate for everyone. You're going to see that there's a very specific population that each of the 4 medication-assisted treatments that's approved by the FDA are used for. And there's a very specific population that they are not used for, that they're contraindicated, in fact, for, and that they're used at different times in the treatment process. So hopefully we'll be able to tease all that out for you as the presentation goes forward. Some of the medications can produce side effects from use. That's real, regardless if you're working in the medical profession or maybe you're an EAP or perhaps you're an addiction professional that's working in addiction treatment. It is not uncommon to hear from the clients or patients that the medications they're taking can produce side effects, and that will be a deterrent for wanting to use that medication. That is real, and I'm going to hopefully be able to point out which ones of those side effects that you can expect and which ones you need to keep an eye on and refer back to a physician if something happens. But yeah, side effects do happen, just like all medications. You can see on the television programs that we're all so used to seeing now. They spend 2 minutes talking about the medication and how it can help you, and then the last 3 minutes in really fast talking tells you about all the things that can happen to you, including death. So we're pretty used to the concept that side effects are attached to medications. But for our purposes, you want to be aware of it because it could be a reason that medications would not be appropriate for that patient. There's another reality that patients don't always take their medications as prescribed. Just, I'm sure as a therapist that are out there, it's difficult to get the patients to show up to the therapy sessions on time or if at all. And that's the only way that the talk therapy is going to work, is if the client physically shows up for the appointment. Same thing for medications. They will not work if they are not taken. And you're running into medication compliance issues at this point, which could be another deterrence factor of making a patient not appropriate for certain medications. And here's a biggie. Medications cost extra money. Some of these are extremely expensive, and I'm going to tell you which ones and tell you what status they have with insurance and how to best get some of these medications covered. But the reality is not everyone can pay extra money for medications. That perhaps that's just not a part of their budget or even their financial means. So, or maybe insurance doesn't cover it, or maybe they're a part of the VA and it's contraindicated for them. We'll talk about all of those considerations, but the reality is they do cost money, which is obviously going to knock out some patients right from the get-go. There's a stigma associated with using medications. Again, as we were talking about with AA, obviously there are people that hold that there must be a white-knuckle abstinence period that comes for addiction. That's the way they did it. That's the way it has to be. And if you don't do that, then you are you're copping out in some way, or perhaps you're not doing it the right way, or not doing it in a way that's really going to sustain long-term sobriety or in recovery. There's a stigma that is real, that must be acknowledged with using these medications. And I hope where you as clinicians and medical professionals come in is to be able to talk openly about that real stigma. There may be clients that come to you that's saying that they are not comfortable going to the AA meetings that you prescribe to them because they feel that they are not going to be accepted. That's not something to skirt away from. It's a reality, and you want to make sure and help them find a home if they're trying to find a self-help group that would best fit for them. Make sure that you're keeping in mind that a stigma really does exist. And then again, some patients don't feel comfortable taking pills or receiving an injection at all. When it comes down to substance abuse, especially when we're talking about opioid dependence or prescription medication abuse, something like that, prescribing yet another medication that would possibly help with their addiction might be counterintuitive for some, and that's a real thing to understand. And again, one of our medications is involving an injection. That might be something that a patient is just not comfortable with at all, and that must be understandable. And some of the medications we're going to talk about, too, in particular, increase the risk of overdose when combined with opiates. One of the realities of our business is that there are lots of polysubstance abusers in our populations. That very, very rarely do you have just a very strict patient that just only abuses alcohol. Most likely they're dabbling in other things, and a couple of the medications will be problematic if that patient is addicted to alcohol as well as dabbling in opiates or perhaps even addicted to opiates. They'll put them in full opioid withdrawal, and we'll talk about that more. Some other not-so-good things is that there is a lack of sympathetic and educated prescribers, and it's not easily available to find one that is specifically trained in addiction medicine and that is able to understand the advancements of pharmacotherapies that have happened over the years and have moved along with that scientific research. And especially in rural areas, these prescribers are not easily found or easily available to reach. The American Society of Addiction Medicine does a great job of trying to push forward this education and getting more prescribers aware of specifically the medications that come along with addiction treatment, but we're still far from the goal. And it's a reality that for some patients, medications could decrease the emphasis on other forms of self-help. You know, even though I'm sitting here saying very clearly these medications are not a magic bullet, that's not to say that some of the clients won't walk away feeling otherwise. They feel that they have maybe this medication on board, that perhaps they don't have to attend that self-help group, or maybe they don't need to come to your sessions twice a week as prescribed, that maybe they feel like that they've got some extra support that can offset some of the other efforts that will really help them for their treatment plan. And that could be detrimental to their treatment and to their success in recovery. And want to make sure to not overemphasize medications and their ability to help support all the other activities that are going on. And like I'm saying, they can give a patient a false sense of security, may help them, may make them think that they could walk into a bar and be able to go to that wedding without having any extra assistance, and think that they might be a little further along than they are if they're doing well on a medication. We want to be very careful with that. So that's an overview of some of the not-so-good things. And so let's dive into some of the good things about it. What we do know is that medications can help achieve complete abstinence from alcohol. That is a proven fact. Medications can help prevent relapse. They can help reduce alcohol consumption. They can help maintain recovery from alcohol. We know from the scientific evidence that this is absolutely true. It can help patients stay in treatment longer, as I mentioned earlier. It can serve as a tool to initiate treatment. And what I mean by that is, I won't dive in too much, but the stages of change model has clearly 3 or 4 steps right before we're going to get to where someone's actually taking the medication. So if you've got a client in the pre-contemplation stage, or even better in the contemplation stage, where they're really trying to resolve some of that ambivalence and get prepared perhaps in the preparation stage to move forward towards treatment, knowing that there's options like this out there that could help them a little bit, give them a little extra support, might be really motivating for them. That it's not just about attending AA or just simply going to see their doctor at regular intervals, or just going into treatment or therapies are their only options. That there's something that on a daily basis that they would be able to do that is addressing that biological component of a disease that they do possess, can really maybe help them move towards the later stages and actually move towards action in that stage of change model. And it really can help support the therapeutic process. Again, there are biological changes that I keep referencing that I promise I'm going to address as we get further in. But those changes could really affect negatively the therapeutic process in and of themselves. If they're going through post-acute withdrawal symptoms that are very uncomfortable for alcohol dependence, then it would be, these medications can come in and help support the work that you're doing, help clear their head a little bit, help reduce the anxiety a little bit, help make it so their brain chemistry is not fighting against them as all of the things that are coming up in other traditional forms of treatment are being utilized. It'll help that process work in conjunction. So just something to consider there. And it can also help reduce absenteeism from work. You know, it's all a part of the cycle. And medications can increase self-confidence. They can help reduce family conflict. And Medications are thought to alleviate cravings. We'll talk about which medications those are. 2 of the medications block the effects of alcohol. Some of the medications decrease the desire to drink. Some medications provide incentives not to drink. We'll talk about which ones those are. And some medications reduce the post-acute withdrawal symptoms. I'll tell you which one that is. And then just finally, medications, as I said, are just another tool to enhance recovery. So we want to make sure that these are firmly being placed in that toolbox. And when you're thinking about how to fit pharmacotherapies into treatment, I keep referencing this biological component. And as you can see here, it's very much like a chair with 4 legs, that we have the psychological components, the spiritual components, the biological, and the social components. And all 4 legs, if you will, of this chair are required to support that patient. And if one of those legs is missing, it's obvious that chair is going to be unstable and not be able to accomplish its goal to support that patient. So all 4 of these components have to be considered when you're addressing a patient's treatment plan and what's best going to set them up for long-term recovery. And that biological component can't be ignored. And you want to make sure that you're pairing all the different options that come out of that toolbox, making sure you're pairing it with that individual. There's a lot of different therapeutic interventions that one can choose from, but you want to be really inclusive of these ideas that are on your screen. And furthermore, you can see from this NIDA chart here from the Principles of Drug Addiction Treatment that right here in the center, you can see that pharmacotherapy is one of the primary ways in which addiction treatment is moving forward. You can see all these ancillary ways in which the client needs to be addressed and have supportive services coming in. But right here beside behavioral therapy and counseling is pharmacotherapy, along with those self-help groups and intake, processing, and assessment. This is where all of you experters out there are going to be starting from. Right underneath that, pharmacotherapy comes right in conjunction, along with the continuing care. So hopefully this is just a visual of letting you know how these medications can fit into the whole plan. So let's dive into the meat here. So understanding alcohol dependence. I firmly believe in order to understand the medications that you might be discussing with your clients or patients out there, you must understand how alcohol dependence first sets in on the brain. And once you can understand those changes that happen in the brain, it makes a lot of sense how these medications have developed and exactly what components of addiction for alcohol dependence is being addressed in that biological nature. And so starting right off, we're going to just go over some super, super simple brain functioning 101 stuff, not spend too much time, but in essence, I feel like it's important to go over some basic brain functioning. So as we know, psychoactive chemicals mostly affect the central nervous system, which contains the brain and the spinal cord. And then the central nervous system is primarily responsible for things like thinking and learning and judgment and all of your emotions and those voluntary and involuntary movements and all of our sensory inputs such as smelling and tasting and hearing and feeling. That makes a lot of sense because psychoactive chemicals are affecting the ways in which you walk and things that you're saying and the perceptions and delusions of what you might be seeing in the real world. It's all very skewed at this point, especially in the thinking and learning and judgment section. And that's due to the central nervous system. And just to break down very, very simplistically, I'm sure you guys are all very familiar with that image on the right. It's the iconic image of a neuron. And essentially the body is made up of millions and billions of little neurons that are commonly referred to as the building blocks of our entire nervous system. And these neurons are located everywhere throughout our entire body and have its own shape and their size and function that are specific to the type of chemicals that it can receive, these chemical signals, also known as neurotransmitters, that it can receive. We know that neurotransmitters are specifically designed to instruct the neuron to do something or perhaps not do something. And the reason why that's important is going to come into how alcohol dependence sets in on the brain. And so again, just generally speaking, we've zoomed in on that image of the neuron that I just showed you, and you've got a presynaptic neuron on your left and a postsynaptic neuron on the right. And so when a neurotransmitter is released, which are those little red dots there in the middle, from the presynaptic neuron, which is on the left, it just goes across that cleft and then attaches itself to what are called receptors on that postsynaptic neuron. That's really all you need to know, is that neurotransmitters are released. They're little signal balls that are supposed to tell the neuron to do something, and they attach themselves on to these receptors. That's a super, super simplistic way of discussing this, but that's all that we need for our purposes. And so just one more other detail here is that neurons work kind of on a lock and key mechanism where those neurotransmitters are going to attach to that receptor. But not all neurotransmitters fit onto the receptors, much like not all keys fit into all of locks. So as you can see, the circle neurotransmitters bind really nicely to the receptors, but the square neurotransmitters do not. So again, very simplistic way of kind of setting the scene here that some of these neurotransmitters are going to attach themselves and cause the neuron to do something, and some of them are not. Some of them might just block that area. So just wanted to keep that visual in your head. We'll revisit this several times as the hour progresses. So for our purposes today, there are 4 main neurotransmitters that are relevant to alcohol consumption and dependence. I'm sure that you're aware of this first one, dopamine, which regulates motivation and pleasure. It is attached to almost all psychoactive chemicals. They release dopamine, as well as eating and gambling and having sex. That releases dopamine as well. We also have opioids. Those are naturally occurring pain reducers that are in our system, also known as endorphins, and they produce euphoria. So we're going to be dealing with dopamine and these opioids. Then here's a new one perhaps for you. It's glutamate. And that's the major excitatory neurotransmitter that usually causes the neuron to do something. And so some examples of what we can pin glutamate on is things like anxiety and insomnia and hyperactivity. So think of glutamate as sort of revving you up. It's causing you to do something. And so you can see with like anxiety or insomnia or hyperactivity, that means your body's a little flooded with something that is causing you to rev up. So think about when we're discussing, remember that when we're discussing glutamate. And then conversely, there's GABA, which is pretty much the opposite of glutamate, which is the major inhibitory neurotransmitter. It usually causes the neuron to not do something. And so some examples of that is just relaxation, sedation, slurred speech. So think about GABA as really slowing the body down. It's causing the body to not do something. Whereas you can see with glutamate, it's revving the body up, causing anxiety, causing things to race through, lots of thoughts, causing non-sleep to happen, hyperactivity. The opposite's true for GABA, which is causing the body to relax and be sedated and have slurred speech, just generally slowing down. So those are 4 main neurotransmitters. Here's another way to look at them. As you might be able to tell from this presentation, I'm really big on visuals and trying to get the main points across. So I've come up with these little icons here to help remind us what each of these neurotransmitters do as we progress in the presentation. And again, dopamine, we've got a smiley face there because it makes you happy. And endogenous opioids, we've got a little man jumping and kicking there and an excitement because it makes you feel euphoric and feel no pain. Glutamate, we've got an up arrow because it's the main excitatory neurotransmitter and generally sort of speeds you up. And then GABA, we've got an arrow going down because it's the main inhibitory neurotransmitter and just generally slows you down. So again, we'll revisit all of these little icons as time goes on. So the exciting thing, as I've alluded to here, is that researchers have pinpointed the exact biological changes in the brain that's caused by excessive alcohol consumption. And we know that there are changes in neurological activities that take place in very specific areas of the brain that cause the adaptation of the brain to the constant presence of alcohol over time. And because they've been able to identify exactly where alcohol dependence sets in what areas of the brain and why it happens, these advances have really afforded researchers the opportunity to come up with pharmacotherapies to directly combat those biological changes that are happening so we can aid in the treatment of alcohol dependence. And it's also important just to recognize that these changes that I'm about to discuss are changes and adaptations in functioning that occur regardless of 1 glass of wine is consumed or 5 beers, or it's the first-time drinker, or an alcohol-dependent individual. So these are just changes that happen with alcohol. And when alcohol is constantly present, then these changes happen more and more. So just keep that in mind as we go forward. So with that said, let's get to some really good meat. This is one of my favorite parts of this whole presentation here. So let's talk about the first process of activity that happens in the brain. Starting off right from the beginning, alcohol is ingested. You gotta drink down some alcohol in order for this process to start. That's the first thing. And then we've got those endorphins and those endogenous opioids, which if you can see that little guy jumping there, remember, it makes you feel euphoric and have no pain. All of those are released from the part of the brain called the arcuate nucleus. You don't need to know that at all, but it's on your screen, it's on your slides to remember for later. But this release of endorphins and opioids that come from this part of the brain then activates these other areas of the brain known as the ventral tegmental area, known as the VTA, and then the nucleus accumbens. You might be more familiar with the nucleus accumbens because that comes up a whole lot with other addictions, specifically cocaine dependence, for example. That's where dopamine is released. So as you might be able to guess, we've got these endorphins being released, which then causes an activation in the VTA and the nucleus accumbens. And then in response, dopamine is released out of those areas. And so as we remember, dopamine makes you happy, makes you smile. So that's got you feeling good. And we know we've got that jumping man from earlier that has got the opioids that are released. So we've got dopamine and opioids now being released from the drinking of alcohol. And so just naturally, intuitively speaking, we know that dopamine is the main reward neurotransmitter, and increases in the nucleus accumbens make that drinker feel good. And so, of course, the brain remembers those good feelings caused by the dopamine and the alcohol, and then the brain desires to repeat that behavior again to get those same good feelings. Of course, that was a really good interaction they just had. So that's the first piece. We're going to hold that one off to the side and think here for a second. What would happen if we were able to simply reduce the effects of dopamine? And then perhaps drinking alcohol would not feel as good, right? If we can just stop that dopamine in its tracks, what would happen? Well, that's exactly what scientists have done. And they've been working for decades to make it happen, and we have 2 medications that work exactly at that point, where we're going to cut off the process and prevent dopamine from ever being released. And so it doesn't feel as good. So we'll talk about that in a minute. So moving on to the second process, it's happening simultaneously as the first, but I've just teased these out for understanding purposes. Starting back again at that first step, alcohol has to be ingested. Now here's where GABA comes in. GABA, as you remember, is that major inhibitory neurotransmitter, slowing things down. So GABA is increased and creates an imbalance in the brain because we now have a lot of GABA. But the brain really wants to keep a balance between inhibitory signals and excitatory signals. That way it doesn't feel overran by either one of them. And that process is called homeostasis. And so when we have an increase of GABA, which is going to make the body slow down, this creates an imbalance, and the brain doesn't like that. Also at the same time, the excitatory signals from glutamate are being suppressed. And the increase in GABA makes the body generally slow down. So if I was standing in front of you, you could see me in sort of a teeter-totter stance where one arm is up higher than the other, and we have an imbalance in that system where we have too much GABA come into play, not enough glutamate. Glutamate's being suppressed, so we are not in homeostasis at this point. And so the brain is generally okay with that if there is going to be a reinstatement of homeostasis. But as we go on, I'll show you what happens when there's a constant imbalance. So just to think here for a second, just the imbalance that I just described with having GABA be more present than glutamate, those inhibitory neurotransmitters, if that's manifested by being drunk, what physical signs do you think you would see in your clients when they actually have alcohol intoxication? So this is a little bit of a trick question to all of these things. If you're thinking about it, it's the slurred speech. They're slowing way down. The incoordination, they're not working as well. Things are getting a little slow, impaired judgment. There's some confusion. There's drowsiness. Well, that directly ties back to probably what you're witnessing with your patients whenever they are under alcohol intoxication. It's because there's an overabundance of GABA, and glutamate's being suppressed, so their body is slowing down. So here's the exact moment. This is the moment in the whole presentation I want you to be aware of here. This is the moment that alcohol dependence sets in. And then the brain has to adapt to the constant presence of alcohol. Because the difference between someone who just has a glass of wine and then goes to bed and that's the end of it is that the brain then can go back to having homeostasis. But when the brain is in a constant state of imbalance, it is going to put itself back into homeostasis. It has to remain in balance. So that means when the brain is constantly exposed to alcohol over a consistent period of time, it is constantly working with an imbalance of too much GABA because alcohol creates too much GABA and not enough glutamate to balance itself out. So this is exactly what the brain chooses to do. It thinks, well, perhaps since we have so much GABA, and I've noticed the glutamate is not really as active as it used to be, maybe we should just try to increase the amount of glutamate activity that's being exposed to. And so we know that the glutamate activity is being reduced, and we know that glutamate's not being able to activate those glutamate receptors like it usually does. So in response, the brain does something that's called upregulation, which means that it increases the amount of these specific glutamate receptors called the NMDA receptors. You don't need to know that. But in general, it's increasing the amount of receptors that are available to even have glutamate attach itself to, in hopes that if there's more opportunities to have this activation, then that will yield more activity. And so it's kind of like thinking if you've only got one hand to catch a ball and you've got 5 fingers, and if the football's being thrown, you've only got this one arm. Well, if you're not catching it every time, maybe let's just add in another arm, or maybe let's add in 500 more arms, and that will really ensure that as the ball comes, you'll be able to catch it because one of them is going to grab it. So that's what's happened here. So now we have an upregulation of the glutamate receptors, and so just as the brain desired, this method of upregulation works, and therefore the balance is corrected. Because now we have a lot more opportunity for glutamate to get some activity, which then can counterbalance all the activity that's coming from GABA due to the alcohol. So now we're back in the same even keel again. We're balanced. But then here's what happened. Because alcohol was what was causing the GABA to be imbalanced, and then the brain has to adjust by making glutamate be increased, now the alcohol that they're used to consuming is not the same amount of alcohol that's going to get them intoxicated as it used to be, because now there's more glutamate on board to balance out the same amount of GABA that used to be all that was required to get intoxicated. And this is where tolerance sets in, because more alcohol is now required to feel that same level of intoxication, which means that it's constantly going to be on this chase of making it so there's more GABA in the system, which means there needs to be more alcohol on board to override what the brain just did to try to counterbalance the presence of alcohol. I hope you guys are following, because I think that is so fascinating. I mean, it just makes so much sense that, yeah, how tolerance works in the brain is that there was an adaptation that said, well, you know what? If I'm always going to have alcohol in the brain, well, I'll just adjust to always having alcohol in the brain, but I've got to get myself back to stable. And so it got itself back to stable, but it did it with the constant presence of alcohol. And so now the brain is only stable when alcohol is on board. And I think that makes some intuitive sense for all you practitioners out there, because what happens when you take alcohol away? That patient doesn't feel normal anymore. So we'll talk about that in just a minute as well. So as you can see from my little graphics on the bottom there, more alcohol is needed to get to that same level of intoxication. So here's just another visual way to look at what I just explained. When a patient does not consume alcohol, they're just normal. They've got the same amount of GABA and glutamate to make their body have homeostasis. Then when you put alcohol on board, you got a lot more GABA, and so there's an imbalance. But in order to offset the amount of alcohol that's on board, the brain has to make some adaptations, and that makes it back in balance again. So as I just mentioned, I gave it away a little bit. What do you think is going to happen when we take alcohol away? As you can see probably from that teeter-totter, we're going to go back in the opposite direction. So stay tuned for that. So here's just one more recap. So to start us off, you got to have alcohol use, which then increases GABA and suppresses the glutamate. That also increases the opioid and dopamine activity, which causes pleasurable effects and drive to repeat the behavior. And so you repeat the behavior, and so therefore there needs to be an upregulation of those glutamate receptors, which then sets in for tolerance, which means there needs to be more alcohol use, which then increases GABA and suppresses the glutamate and increases opioid and dopamine activity, which makes the drinker feel good and they want to do it again, which means the brain's got to adapt some more, which means that the drinker has to drink some more, which starts it over and over and over and over again. So I hope that makes a lot of sense to you here. So let's do one of our first polling questions here. So Sylvia is at happy hour with a group of her colleagues from work. And after 2 cocktails, she feels jubilant and engaging. She's laughing a lot. She describes herself as having a nice buzz. So the question is, which 2 neurotransmitters are involved in making Sylvia feel like this? You can select 2 on your screen. I'm going to give you just a few seconds to do that, and we've got one more coming right after, so if you missed this one, you can play for the next one. All right, so I'm going to close it down here, and let's look at what you said. So it looks like that most of the individuals here got it right, which is that it's going to be dopamine and opioids. You remember those are the two, the smiling face and the jumping man. That's what makes that individual feel like they're having a great time and got a nice buzz, the dopamine and the opioid. Okay, so now we've got Michael, who's a 35-year-old male who has experienced blackouts and is unable to control his intake of alcohol. He's noticed that it takes increasingly more alcohol to achieve the same level of intoxicating effects that he used to enjoy. So which of these two neurotransmitters do you think are involved making Michael feel like this? So just take a second there. You can pick amongst dopamine, GABA, glutamate, or opioids. Okay, let's see what you got here. Great. The crowd is absolutely catching on. So GABA and glutamate, those are the ones that are responsible for Michael's feeling like this. So good job, everybody. So that concludes the portion that is talking about how alcohol dependence sets in on the brain. Let me just quickly check my time. Okay, great. We're moving along. So now we're going to jump into the actual 4 FDA-approved pharmacotherapies for alcohol dependence. And as I hope that you can see, we're building on each other here of the information from the beginning to now where we learn about how alcohol dependence sets in on the brain. And so now we're going to start talking about the medications that are used to help offset some of those changes. As I've made super, super clear, none of these medications are the next great thing. They are not in any way a magic bullet. And even more so, NADAC is not endorsing any of them to be better or worse than one another. We are simply here to just try to educate addiction counselors and other medical professionals out there to be as familiar with pharmacotherapies as possible. And in reality, you guys are the ones that see the patients the most and are in the best position to possibly recognize some of these danger signs and maybe some of the abnormal side effects that shouldn't be appearing. And if they are, you can direct them to their prescriber and get some assistance with that, and even more so to monitor compliance. So that's why we think it's important to talk about the things we're going to be talking about. But I do want to give this big black box warning here that if you are not a prescriber, it is outside of your scope of practice to discuss in great detail recommending or not recommending a medication, and that's something that's really left between the client and the prescriber. And if any questions at all pop up about the medications, you really are supposed to direct those to a prescriber and make sure that they're under their care. So just a couple of warnings there. So the 4 FDA-approved pharmacotherapies, here's what you guys have all been waiting for. What are they? The first one came out in 1951 called Antabuse, also known as disulfiram. And you can see a big, giant gap from the time period of 1951 until our next medication came out, which was naltrexone. Its marketing name is Revia or Depade. It's in generic status now, so there's a lot of different companies that sell it. Those are 2 of the most common. So as you can see, there was, over 40 years that passed to where there was a lot of information and, I think, stigma that was created based on pharmacotherapies for alcohol dependence, because all that was around from the 50s to the 90s was Antabuse. And as you're going to learn, Antabuse is the medication that causes you to get physically sick if alcohol is consumed with it. And so obviously that's not a medication that's appropriate for everyone. And if that was the only thing on the block and courts were starting to mandate that, and that was what medications for alcohol dependence started to be compared against, it wasn't a really great start. So we'll talk about who is appropriate for using Antabuse and how these other medications have changed. So in 1994, we got naltrexone. Then another 10 years passed and we got Acamprosate. That's the marketing name for it. It's actually Acamprosate calcium. And then a couple of years after that, there was a naltrexone for extended-release injectable suspension marketed as Vivitrol. And what Vivitrol is basically an injectable form of naltrexone. That is a pill. So we'll talk about those differences more in detail in just a minute. So that's the timeline of these 4 medications we're going to talk about and when they were actually FDA approved. So you can see, medications for alcohol dependence have really heated up over the past 20 years, and we've gotten 3 out of the 4 during that time period. So let's learn about the differences. Jumping right in, let's talk about Acamprosate. You can see pictures of it on your screen there. As I said, its generic name is Acamprosate Calcium, and it's marketed as Camprol. Its purpose is to encourage sobriety by reducing the post-acute withdrawal symptoms from alcohol dependence. The important piece right there, it's not acute withdrawals, they're the post-acute withdrawal symptoms, and I'll talk about what those are and the differences between acute and post-acute and how that can be helpful for the client. And then the indication is for the maintenance of abstinence from alcohol in patients with alcohol dependence who are already abstinent at a treatment initiation. We're going to talk about why this is important. This is the only medication evolved that has to have a consistent period of abstinence prior to taking the medication. And the reason is you got to get to those post-acute withdrawal symptoms. I'll talk about that more in just a minute. And it was approved in 2004. You can see images of these pills right here on your screen. They are 333 milligrams, so that's about the approximate size of the pill. Just kidding, for all you guys out there that are falling asleep, that was a joke. But no, they are large pills. They're 333 milligram tablets. So when you think about an average Tylenol and ibuprofen, you know that's a 200 to 200 milligram pill. This is 333 milligrams, so it's a little bigger. And the reason I bring that up is that the required dosage for this medication is 3 times a day, 2 333 milligram tablets. So they're taking 6 of these larger horse pills over the day for a consistent period of time. That may come up as being problematic because I personally can't get through a Z-Pack by myself. And so if I can't do it for 10 days, taking medication 3 times a day, that would be a real compliance issue that you'll have to contend with when talking about Acamprosate with clients. The other thing to note about this medication is that it cannot be crushed or halved or diluted in any way. It cannot be mixed with food. It has a coating on the outside that is designed to take it through the gut and through your stomach to get it to the place it needs to be for digestion. And if it is crushed or halved in any way, then the medication will be released too early and it will not have the effect that it needed to have. And as I mentioned before, patients must be finished with the medical detoxification process and abstinent from alcohol at the treatment initiation. So the reason for that is that this really focuses on post-acute withdrawal symptoms. And those withdrawal symptoms don't usually start occurring until about a week or so after the patient's last drink. Because as we know, for that patient, if they stop drinking, they're going to go for the acute withdrawal symptoms, which are very uncomfortable. That's when you might get the DTs and lots of sweating and shaking and things like that. And that lasts for the first, 4 to 5 days, let's say, up to a week. And that's the medical detoxification process that really needs to be monitored by a medical professional because this is the only addiction to which if you're withdrawing that you could die from, the withdrawal symptoms. Everything else is very uncomfortable for other addictions, but for this one actually has some fatal consequences if not monitored appropriately. So again, once they're finished up with that medical detoxification process, then they've been abstinent, and that allows their brain to move past the acute withdrawal symptom phase into the post-acute withdrawal symptom phase. So it makes sense that the abstinence requirements must be that you are abstinent the whole time. Otherwise, the brain is not going to move into that second phase of withdrawals because it's been fed with alcohol, which completely stops the withdrawal process. So we'll talk about that a bit more. There is no difference between the starting and maintenance and ending dosages, meaning there's no need to taper off as someone stops or taper up as someone is starting. This medication is in no way addictive. It doesn't have a high abuse liability. There are no withdrawal symptoms reported when the medication is ceased. So essentially, this medication is not addictive by nature, and so you don't need to monitor the beginning, ending, or maintenance doses. There's also been no reports of misuse, such as injection or smoking or diverting the medication in any way during the clinical trials. So in essence, this medication is not being sold on the street. It's not being cooked down and injected for any purpose. It can't do anything helpful in that way that perhaps a drug user would be looking for. The risk of overdose is extremely remote, with the most severe side effect being diarrhea. And then this medication is brought by Forest Laboratories, and so there is a patient assistance program that's available. And right now, it's to the best of our knowledge, when this presentation was made, it was covered by most insurance carriers, including Medicare and Medicaid, and the VA, but only if naltrexone was contraindicated. They're mostly using naltrexone, and so if for some reason you're not able to have naltrexone, then you can move over to Acamprosate, but still working its process out on that particular avenue with the VA. So how does it work? So it's thought to be what's called a glutamate receptor modulator. And what I'm physically doing with my hand, I wish you could see it, is like when you're working on your stereo system, for example, if anybody still has those anymore, when you're that big knob where you turn down the volume, I'm just turning the volume down just a little bit on glutamate. So it's a modulator. Think about it, the modulating of noise when you turn that speaker volume down. This is a glutamate receptor modulator. And so where this comes into play is that if you remember, after the repetitive consumption of alcohol, you have the brain that's suppressing glutamate activity, which then the brain needs to be in a constant state of balance, and so it increases the amount of glutamate receptors, which therefore counteracts those alcohol depressive effects. And so, as I alluded to before, when alcohol is not present in the alcohol dependence body, then glutamate is able to behave normally. But that means that there's a lot more glutamate receptors that are able to behave normally because of that upregulation. So now there's more glutamate activity than normal. That wasn't what the intended purpose was. We needed to have a lot more glutamate activity possibilities because it was being counterbalanced by GABA because alcohol was present. But when alcohol is not present, that GABA is not shooting up to high numbers, so therefore there's way more activity than necessary for glutamate. And because glutamate is that main excitatory neurotransmitter, there's an imbalance between inhibitory and excitatory signals, which results in alcohol withdrawal. And so I'm sure that you're familiar with the symptoms that look like hallucinations and tremors and seizures and insomnia and mood disturbances, anxiety. You can see how all of these would directly correlate back to an overactivity of glutamate. And now you understand why there's an overactivity of glutamate. It was always there, designed intentionally to counteract the constant presence of alcohol, which causes GABA to be increased, which suppresses glutamate, which means you need to have more glutamate in order to balance it out. And so when that GABA functioning is decreased back to the levels that it should because alcohol is no longer present, there's a lot more activity in the body, and you can see, and I'm sure you have in your own experience, these are very powerful motivators for people to resume their drinking. And so if you can get them through the medical detoxification process in those first few days and keep them sober, they'll get past that, and then they'll move to an area where there's the post-acute withdrawal symptoms, which are less intense, and we'll talk about those more in a moment. So how acamprosate works is that you can see those little A's on your screen right now. So on the left-hand side, the presynaptic neuron, it modulates glutamate by first just attaching itself onto the vessels that are releasing neurotransmitters for glutamate, saying, you know what, I know all of you guys wanted to go over to play with the postsynaptic neuron, but we're only going to let a few of you guys out. So it's really that big security guard that's just only letting certain people in. Just the pretty people, the people who are in nice dresses, the people who are able to pay a lot at the bar. I'm just kidding. They're just neurotransmitters, just glutamate going across the cleft. So that's the first place that it's being modulated. Not as many neurotransmitters for glutamate are being released in the first place. And then the second place is that it's attaching itself more onto the side there in place of that receptor to make it so not as many neurotransmitters for glutamate can attach to those new glutamate receptors. So essentially it's getting some limited at the beginning portion, and on the back end it's only letting so many people actually through the door by the time it crosses over. So that's why it's thought to be a modulator. So here's that teeter-totter example I was giving you before. So again, we've got a normal amount of function between GABA and glutamate, and alcohol comes on board and causes an imbalance. Then the brain adapts, which causes tolerance and even to back out again. But then once the alcohol goes away, we've got way too much glutamate because that adaptation had happened, which causes acute withdrawal. And after that first week, and once acute withdrawals sort of make their way through and process out of the body, you can see that middle, on the bottom middle teeter-totter. It's not exactly back to being even again. And that's the post-acute withdrawal symptom phase. Because this imbalance, that small little bit that still needs to go back in order to make it all even again without the presence of alcohol, that's going to progress for up to a year in an alcohol-dependent brain. And that produces those post-acute withdrawal symptoms that are quite uncomfortable, that could lead someone to go back to drinking to try to settle their body out a little bit. And that's where acamprosate comes in. It just balances out that last little bit by being a modulator for the glutamate. And so here are some side effects that are an actual effect of the acamprosate. You can see that these occurred in 3% or more of the patients during the clinical trials. I want to show you what all of these are because, again, as we've seen from commercials, there's a lot of side effects that we're used to hearing about. The main one here is diarrhea, is the main one that got presented for Acamprosate, but it was reported that it phased itself out after taking the medication for a little while. And even more so, the reason why this would be important is if you've got a client that's coming in that you know is on Acamprosate and they report some really outrageous symptoms from it, you can discern perhaps from this presentation which ones were probably related to the medication and which ones might be outside of the norm that they definitely need to get some get some medical treatment about. And so we know that these medications should not be given to anyone that has any sensitivity to Acamprosate, as well as there's also a good thing about this medication is that it doesn't have any contraindications for liver impairment. As you can see that there is contraindications for kidney impairment. And how that becomes really helpful is that when you're thinking about alcohol dependence, a good portion of this population is going to have liver impairment due to the nature of excessive drinking and the effect that has on the liver. And so when you're talking about recommending some additional medications, obviously most of those medications are processed through the liver and has a major effect on the liver, and so there's already impairment. That's not exactly the best matchup. And so this medication actually does not have any contraindications for liver impairment, but you do need to keep in mind that there are contraindications for severe kidney impairment. Thing to notice here about Acamprosate that I think is super important for the work that we do is that there was a noted increase in adverse events of a suicidal nature during the clinical trials. There wasn't a difference between the amount of completed suicide, but there was an increase in that suicide ideation, there was an increase in suicide attempts, and there wasn't a difference between completed suicides. But the major thing to remember here is that not only do you have an individual that is changing a lifestyle here that they're very used to, there's probably going to be some co-occurring issues, mental health issues that will be coming on board as well, or surfacing for the first time, or surfacing in a different way. And then if they're on this medication, there might be a little uptick as well for those adverse events of a suicidal nature. And what this means for you guys as clinicians is that we want to keep really close tabs on these patients, just like we do for all patients that are going into recovery. You might want to watch them a little bit closer. Make sure you're using a depression assessment of some sort, maybe the BSSI or the HDI would be helpful. There's lots of them out there. But either way, you want to monitor closely for depression and for suicidal attempts for Acamprosate. So that's what I've got about Camprol. So moving on to the next one is disulfiram, also known as antabuse. And this works by discouraging drinking by making the patient physically sick when alcohol is consumed. That's exactly what it does. But I really enjoy what the indication says. They really state it. It's an aid in the management of selected chronic alcohol patients who want to remain in a state of enforced sobriety. So that supportive and psychotherapeutic treatment may be applied to best advantage. So the key word there is selected chronic alcohol patients who themselves want to remain in a state of enforced sobriety, because that's the reality. You cannot drink on this medication or it's going to make you sick. And so if there's a patient that's on board with that, and there are lots of situations where that would be appropriate and really helpful, as we know, deterrence is a great reason not to do something. I personally, beyond not being a person who could kill someone, I really don't want to go to jail for the rest of my life and face the death penalty. The reality of that deterrence does weigh on me and does affect my decisions of whether I'm going to run a red light or whether I'm going to speed through that school zone. And so deterrence here, knowing that you're going to get sick if you drink, is a really big factor to keep someone sober if they want to be in that state of enforced sobriety. So it is just one 250 milligram tablet that you take by mouth just once a day. It can be crushed or diluted or mixed with food. The only abstinence requirement is that you take it at least 12 hours after the last consumption of alcohol, and that makes sense. If you've got alcohol in your system and you take this medication, it's going to make you sick. So you want to make sure that alcohol is processed through the body before this medication is taken. And there is a starting dose that is just a maximum of 500 milligrams, which you can see is double of what the recommended dosage is for a day. And that just starts them off for once a day for 1 or 2 weeks, and then you can go down to the 250 milligram tablet. But there's no reason to taper down after that. There is a possible risk of overdose, but it's not very high. Again, this medication is not addictive in any way. It's not being sold on the street or diverted in any way. And it is covered by most insurance carriers, including Medicare, Medicaid, and it's used by the VA as well. So how it works is by blocking the oxidation of alcohol during the acetaldehyde stage. And essentially, you don't need to know any of these words, but what happens is that alcohol is broken down in the liver by this enzyme that's called alcohol dehydrogenase, and that's turned into acetaldehyde. And then this acetaldehyde is then converted by an enzyme, acetaldehyde dehydrogenase, to acetic acid. Basically, it just stops that process from happening, and so it makes it so acetaldehyde dehydrogenase has to accumulate in the system, in your blood, 5 to 10 times higher than it would normally with just alcohol alone. And acetaldehyde dehydrogenase is actually a poison, and so whenever it accumulates in your system, it causes what's called this disulfiram alcohol reaction. And what that looks like is that it's throbbing in the neck and head, brief loss of consciousness, throbbing head, lowered blood pressure, difficulty breathing, marked uneasiness, copious vomiting, nausea, flushing, sweating, thirst, weakness, chest pain, dizziness, palpitation, hyperventilation, rapid heartbeat, blurred vision, confusion. It goes on, and as you can see from this list, it's a very uncomfortable experience. So the whole purpose is for someone to recognize that if you drink on this medication, this is going to happen. So it might occur to you, what happens if they don't take the medication? Yeah, that's one of the fatal flaws with this medication, is that if you've got a patient who is bent on drinking that weekend, maybe they've got a wedding or it's football Sunday, and they're thinking ahead of time, you know what, I'm just not going to take my medication today. That way I can go to that party tomorrow, easy breezy. And so if the medication is not consumed, then obviously there's not going to be a disulfiram alcohol reaction because there's no disulfiram on board. So that is one of the flaws with this medication. But otherwise, it works pretty well for its intended purpose, which is to put a patient in a state of enforced sobriety if they want to. And so the reaction lasts for about 30 to 60 minutes, but it can continue for several hours. It's basically proportional to the amount of alcohol that's consumed. So if you've got a patient there that is not a non-believer that this medication is going to make them sick, and they go in and slam 3 beers or have a couple of shots right off the get-go and want to test it to see how it's going to work, or maybe perhaps they think they can override it by having more alcohol than normal, then that's going to have a more pronounced reaction. These are some of the common side effects that happen with the medication itself, not the disulfiram reaction if it's combined with alcohol. It's just the medication itself, with the biggest one being that metallic or garlic-like aftertaste. That's something that does occur for several patients, and it supposedly is able to phase itself out after taking it habitually. If you see of any of the symptoms that are on the right side of your screen, that's indication of some liver impairment, and so you want to make sure and send these patients directly to their physician. And you can see some other serious side effects that are there on the bottom of your screen to be aware of as well. I'll obviously want to send to the prescriber and get medical assistance if any of these things are happening. The big thing about disulfiram is that it shouldn't be given to anyone who is currently intoxicated or who is going to be consuming alcohol. Some horror stories, or maybe they're even urban myths, I'm not sure, but you can imagine how it's possible that you've got a disgruntled wife, for example, who is tired of her husband coming home getting drunk all the time after work, and since this medication can be crushed up or it can be taken with food, you know, you can easily hide this medication and give it to someone without their knowledge. That is not a good idea, and even more so, a patient is really encouraged to carry around a card that says that they're taking disulfiram. That way, if they do have any reaction at a bar or with other people who are not aware that they're on this medication, that reaction I described is going to be pretty pronounced and pretty scary to some people. And so we want to make sure that medical professionals know that could be a reason that patient is experiencing those side effects, or that's actually what's happening. As I told you, patients should carry that card, and those cards can be obtained from Odyssey Pharmaceuticals, which is who makes disulfiram at this time. And just something to be aware of is that there are other things that can trigger a disulfiram alcohol reaction without consuming alcohol. And that would be things such as certain aftershaves and cough syrups, even exposure to vapors and paint fumes and paint thinners, varnishes, things like that. That also can trigger this reaction. And so it's not a surefire bet that if your client is reporting that they got really sick while taking this medication, that they for sure drank on it. There might be some other explanation to go along with it. You know, rubbing alcohol, some lotion have alcohol in them, and the body doesn't know the difference between drinking alcohol and rubbing alcohol, so that could cause the effect. So that's disulfiram. Moving on to our last two medications, which both of them are naltrexone. I'm going to talk about them a little together, but also a little separate. So first off, we've got the pill form that came out in 1994. It is marketed as Revia and Dep-Aid, and its purpose is to discourage drinking by decreasing the pleasurable effects experienced about consuming alcohol. And it is aided in the treatment of alcohol dependence and for the blockade of externally administered opioids. We're going to talk about what that means, because naltrexone is actually a medication that's used for both and is FDA approved for both alcohol dependence and opioid dependence. I'm going to explain why that is true in just a second. So this daily prescription is just one 50-milligram tablet taken by mouth once a day. It also can be crushed or diluted or mixed with food. And in order for a patient to be eligible for this medication, you'll notice that abstinence from alcohol is not required. But there is a requirement for abstinence for opioids. You cannot have taken opioids within 7 to 10 days within taking this medication. And so how that becomes important is how the medication works. I'm going to jump forward to that right now, which is, if you remember, we've got our happy dancing man over to the side, which indicates that opioids are being released. So that makes a lot of sense. And when you drink alcohol, the opioids are released, which makes the guy feel happy and euphoric. But then that activates the areas of the brain known as the VTA and the nucleus accumbens, which then releases dopamine. And from that smiling guy, you can see that that makes you happy. So we've got opioids, we've got dopamine, we've got a really happy drinker right now. And so the brain remembers those good feelings, and they want to do it again. And so how naltrexone works is that it sits on those opioid receptors and blocks them. And so there is no way then for when someone drinks that they do trigger the opioid release, but the opioids are not able to then sit on these receptors, which then goes forward and creates a dopamine release. So it really just stops it right there in its tracks. And so it diminishes the good feelings of drinking alcohol, and you know, the reinforcing side effects are really reduced for drinking. And so, again, just to recap, when naltrexone is present, those opioids are released, but they are not able to bind to those opioid receptors because those naltrexone pills are sitting right there on the receptors and blocking them from being able to do so, which then means that the VTA and the nucleus accumbens are not activated, which means the dopamine is not released, and that drinker does not feel the same level of reinforcing effects and reward from consuming alcohol. And so this essentially is one of those things where the studies didn't show that it increased complete abstinence from alcohol, because the whole thing about this medication is that you got to kind of be a believer. And so when you're talking about a clinical trial where you start on and say, you know, here's how much you drank yesterday, hopefully you won't drink another drink after this, that's not very realistic for this type of medication, because this medication in and of itself is one that you can drink on it. You sure can, and you're not going to have any negative effects. It's not going to make you sick. But the whole point is to make it less pleasurable when you do drink, so you are able to make the decision to say, that really wasn't as fun as I thought it was going to be. I didn't really get that same buzz. It just didn't feel that great. I mean, didn't really feel like anything. What's the point? I think I'll be able to let go of this a little easier than I thought I was going to be able to, because those reinforcing effects of feeling so good when drinking are diminished or reduced or eliminated altogether. So that's the big draw here. I did skip a slide back here. I want to go back to real fast, make sure you don't miss the information, which is essentially that overdose is possible, but they've given doses up to 800 milligrams, which is like four of these pills. I'm sorry, which is 18 of these pills, but no serious side effects were found. Just like all the medications I've talked about today, it is not addictive in any way. It does not have a high abuse liability. You do not develop tolerance. You do not get withdrawal symptoms when stopping the medication. This is not being diverted in any way or sold on the streets or injected in anybody's arm. However, the big thing to note about this medication is that naltrexone will immediately invoke opioid withdrawal symptoms in patients who are physically dependent on opioids. And if we go back to this same screen right here, this tells you why. Because just like with alcohol, when opioids are released, they're going to bind to these opioid receptors. But there's naltrexone occupying those receptors, so opioids can't bind to those receptors and give that same effect. Same thing's true whenever someone takes an oxycodone or is on morphine or is taking Percocet, for example. Naltrexone is still sitting on those exact same neurotransmitters. I'm sorry, those exact same receptors. And so therefore, taking a Percocet when naltrexone is already in your system is going to produce zero effect whatsoever. They will not get high because the medication cannot be overridden by having the opioids being on board. But then conversely, if a patient already is addicted to heroin, for example, and they shot up an hour ago and they have heroin, which is an opioid, sitting on their opioid receptors, naltrexone is strong enough to kick off all of the heroin, all opioids, off of the opioid receptors, and is going to make it so it occupies those receptors, which in turn will make that opioid-dependent individual go immediately into withdrawals because there is zero opioids that are sitting on those receptors. And the only way they're avoiding those withdrawal symptoms that they fight and chase away every single day by doing, hit after hit, is to make it so they have some opioids sitting on those receptors. Otherwise, they're going to go into withdrawals. So naltrexone is going to take over all those receptors and make them immediately go into opioid withdrawal symptoms, which is very uncomfortable. So that's why it's super essential that the individual that's starting to take naltrexone has not had any opioids in their system for 7 to 10 days prior to starting this. That way they won't go into opioid withdrawal. Another thing to consider about this medication is that if you have an individual that's taking naltrexone and they get into a car accident and they need to be given morphine for some reason, that morphine is not going to work either. That's why it's really important for doctors to know and for a patient to carry around a card saying that they're on naltrexone, because if they need to be go under anesthesia or be prescribed pain medication, I mean, this is something that has to be made aware to the medical professionals that will be working on that individual, because naltrexone is binding to those receptors pretty strongly. So as you can see on your screen that there are some side effects that come along with naltrexone, pretty simple, pretty similar to what other medications will bring. Nausea was the biggest one, but it generally phased itself out after taking it for a while. And those symptoms at the bottom are usually due to some sort of liver impairment, so you want to make sure and move that patient to the prescriber and get medical assistance if you're noticing any of this with your patient, so they're reporting any of that. So as I said, this medication should not be given to anyone who is physically dependent on opioids or they're currently undergoing opioid withdrawal. That's not very pleasant. And if they're currently receiving opioid analgesics, I mean, this could mean also that there's a patient that has back trouble. They're not physically dependent on opioids, or I should say mentally dependent on opioids, but they have been taking, as prescribed, opioid analgesics for some reason. If they are given this medication, naltrexone, to help with their alcohol dependence, the body doesn't know a difference between when you should have analgesics onto your system and when you shouldn't, and what naltrexone should override. It's going to override everything. So just something to consider. And you can administer a naloxone challenge test, also known as Narcan, or maybe a urine screen, just to verify that patient is not going to be put into a really uncomfortable state. So that is naltrexone in the pill form. So going on to naltrexone in the injectable form, this is the exact same medication. There is no difference in this medication when it's in the injectable than it is with the pill. The only difference is that it's actually an injection. And so just like for naltrexone in the pill form, it's for the treatment of alcohol dependence in patients who are able to abstain from alcohol in an outpatient setting prior to the initiation of treatment. This is one injection every 4 weeks in the deep muscle in the buttock. And the key about this is that it does not go home with the patient. It is administered by a healthcare professional and should alternate buttocks each month. So this medication is never going to be administered by the client. You have to go into a doctor's office for it. And so that really helps with it being diverted. It really helps if someone, is going to misuse it or with overdose potential. It's always going to be administered by a healthcare professional, so hopefully there's not any neglect there, so it's a safe treatment. And just like with its pill form, it's got to be taken at least 7 to 10 days after the last consumption of opioids. And all that's required for this medication is to not be actively drinking at the time of administration, meaning just don't have a beer in your doctor's office when you get this shot. So as we talked about, there is a risk of overdose, but not a very high one, and even more so, the risk of overdose is dramatically decreased in comparison to other medications because it's going to be administered by a healthcare professional. There is no report of being addictive or tolerance or withdrawal symptoms after the medication ceased. But again, if you are administering naltrexone in whatever form, it will invoke opioid withdrawal symptoms in patients who are physically dependent on opioids. That's with either prescription. And so here's where the big kicker is that at the time of the development of this presentation, there was approximately 90% of patients that were able to receive insurance coverage with no restrictions. It does have a J code for payers at this point, but the last figures that we got was the shot is around $700, and that's for the medication itself. And then there's also, of course, a doctor's visit on top, a charge for a nurse, things like that, other medical expenses that come along with it. So this is a very, very expensive medication at this point. It is not in generic form yet. It will be many years before that happens. And so, of course, with any new medication, the trend usually starts off with a very expensive price tag. And as it becomes more available and more widely used, and the price tag goes down, and then when it goes into generic status, it becomes reasonably affordable. We're just not there for this medication. So consider that when you're talking to your patients about extended-release naltrexone. The only difference of extended-release naltrexone and the pill form is that you get 28 doses of naltrexone in one shot, and they only have to come in once, and they don't have to do a daily medication, so there's no issues with compliance. But you should note that this is not an implant, which is different than an injection. An injection is going to stay in the system, and there's no way to remove it from the body once it has been injected. So patients need to be made aware of that. So here is another polling question. I can see our time is running a little short, so let's just quickly go over this one. So how often do you feel that your patients take their prescribed medications when it's not being administered by a treatment provider? So just take your best guess of what you think that is. Okay. Well, again, it was another one of my trick questions. I'm so sorry for those. But the truth is it's all over the board. It really has to do with the client themselves and what the medication is and what the side effects are that are influenced, whether they're going to take it a lot or a little or sometimes. But the point would be is which of these FDA-approved medications do you think has the highest compliance rate for taking the medication as prescribed? You guys are exactly right. Extended-release naltrexone, because obviously if you go into the doctor's going to do it right. They're going to give you the medication, and you are set for another 4 weeks. So that makes it a lot easier for some patients. The side effect of note would be nausea and injection site tenderness. Obviously, with the shot, you're going to get a little of that. And the nausea did dissipate after some time of being on a shot for a couple of months. And just like with naltrexone, just don't want to give it to anybody who has physical dependence on opioids or undergoing opioid withdrawal. So those are the 4 medications that I can talk about. And I see that we've got about 5 minutes together, so I want to do just 1 or 2 of these quick little reviews. So let's read this aloud together here. So Michelle's family has brought her to treatment after continued frustration over her binge-style drinking that's now resulted in her 3rd DUI arrest. Her husband is estranged, and she has lost her job due to her failure to report to work and complete assignments. Michelle's inability to deal with her strong craving and urges to use is triggered by places she frequents and the friends she associates with. So the question that I have for you is, which pharmacotherapy do you feel is most appropriate for Michelle? You can check more than one. I'm going to give you a second to fill that out, and then I'll discuss it with you guys, but mostly amongst myself since I can't hear you right now. So I'm going to close the poll and show the results of what you guys thought. So it looks like we've got a nice spread. So here's what I would say about Michelle, is that she's clearly got some issues here that are some big red flags. And so I don't see any reason that she would want to be on Acamprosate. Because as we can see here, it seems like that she has binge-stopped drinking. It doesn't seem like she has a period of sobriety. And so for Acamprosate, she's got to be in those post-acute withdrawal symptoms. So she wouldn't be a candidate for Acamprosate unless she has that time period of sobriety. Disulfiram could be an option for her because it seems like that she has some issues with, resisting those strong cravings, and disulfiram could really be a way to give her some of that forced sobriety, although I'm not sure that she's a patient who would want that and that would take the medication as prescribed. You can see here she's got a couple other things that I would want to address that have nothing to do with medication, which is the fact she's drinking and driving so many times and involved in the criminal justice system. She's obviously having some relationship issues. She doesn't have a steady job, and she's clearly not reporting to work, and she's missing assignments, and she's still going out with friends that are clearly drinking around her. So it doesn't seem like she has an environment that's set up to even be able to get sober at this point. So beyond thinking about medications, we've got to think about the holistic treatment of Michelle, and pharmacotherapies are not going to be a magic bullet for her. Maybe extended release naltrexone or naltrexone would be helpful, because if she is going to go out to drink, maybe it just would be a nice motivator that it doesn't feel as good. But again, that's a consideration, but she's not a surefire candidate for all of these. So moving on, let's talk about Jamal. Jamal's past use of heroin and heavy use of alcohol has forced him into a residential treatment center with a court order. He's been detoxed and withdrawn from heroin. However, Jamal's biggest fear is his use of alcohol, and the quick fix it gives him will prompt his return once again to regular heroin use. So let's see what medication you feel is most appropriate for Jamal. Okay, I'm going to close this poll, and let's see what you guys thought. So 19% Acamprosate, 20 for disulfiram, 23 for naltrexone. You got about half people say extended release naltrexone. Okay, that's fantastic. The key things that I want to point out about Jamal is that he has a past use of heroin and alcohol dependence. So I'm immediately going to think of these two medications, which is FDA prescribed for both, or FDA approved for both opioid and alcohol dependence. So we want to look carefully at him. But my main concern is that we would really want to make sure that he still is not using heroin, that he hasn't relapsed on that. Because if he hasn't relapsed, then he would be an excellent candidate to take extended release naltrexone or naltrexone, because if he did happen to relapse by either drinking alcohol and that led him to want to go do heroin, naltrexone would be sitting on those receptors and would not cause a high from him using heroin that first time. Of course, at some point, naltrexone can be overruled, and at a certain point, it is overridden, and you can feel it. But that also puts that patient into a very quick area of possible overdose. But regardless, thinking about Jamal further, he could be a candidate for Acamprosate, because he is probably in that post-acute withdrawal symptom range. So that could be something that could help him with those last jitters that are still being corrected in the brain. And again, disulfiram, that's a surefire way. If he is really eager to want to make sure he doesn't go back to drinking, which he thinks then would make him go to heroin use, then of course, disulfiram would be a surefire way to make that happen. So there were a couple more examples that I have, but I'm going to keep that for you to review on your own. And in our last few minutes, let's just go over a few last housekeeping items so you can make sure and get everything that you got here from us. But that's all the content that I have for you today. I hope that you surely learned a little something there. We've already got a lot of questions that were submitted throughout the presentation, so thank you so much for those. And I'll make sure and provide answers to all of your questions on our website. Just give me just a few weeks to make sure and get those questions answered and posted. I see there's a lot that have come through. And if you wanted more information on this topic, NADAC has a lot of materials and products that are available. You can see a lot of those on your screen right now. The Pharmacotherapy Integrating New Tools into Practice is where this presentation came from. This is an 8-hour home study course that you can do on your own, and we also do face-to-face, and so I've condensed it into an hour and a half today, but there is a training manual that goes along with it if you're interested in that toolkit. And then beyond that, we also, as I mentioned at the beginning, have the ins and outs of medication-assisted treatment and recovery for opioid dependence. So if you liked my style today and you liked how I broke things down, I'm going to do the exact same for you next month for opioid dependence. And this is a part of the regular NADAC webinar series that we premiere new titles each month, and it's always free to all professionals, and CE credit is available. So you can just go to nadac.org/webinars and check out our on-demand webinars, including our upcoming schedule. And as I mentioned at the beginning, this presentation was brought to you through the collaboration of NADAC and the BIG Initiative and the National Expert ATTC and the NORC at the University of Chicago. These are really fantastic organizations to work with and do in and of themselves independent work that is really spectacular. And so as you can see on the website I'm showing you right now, one of the initiatives through the BIG Initiative is the Hospital Expert Initiative, and that's at hospitalexpert.web.com. You can go there to see a lot of their webinars and their free online resources. Also, the same is true for bigexperteducation.web.com. That's specifically for EAP professionals that are working around expert and alcohol dependence and other addictions. And then we also have ireta.org/webinars. They also have a monthly webinar series that is trying to promote educational opportunities and resources. So please just browse on all of these websites, and I encourage you to set aside some time and just take advantage of all these free opportunities that are available to you. And thank you so much to all of our partners that helped make this happen. I know I'm the voice and the one that works for NADAC, but it really was a collaboration, and I thank you all for being a part of it. And just one more time briefly for our latecomers, if you wish to receive CE credit for participating, you must pass the online CE quiz that's located at nadac.org/webinars. It's also in the chat bar onto the side. You can access the CE quiz directly from there, and I am going to send you a link to it in the follow-up email that I send to you. So certificates are free to NADAC members, otherwise they're $20, and this applies to those who are logged in today for the live presentation and for those who are watching the on-demand version. So if you didn't get all of your questions answered on this topic, you're welcome to contact me through the contact information on your screen for myself, or you can type into the chat box near the live presentation right now. And the websites that you see for all of our partner organizations are listed here as well. So please feel free to reach out to any of us if there's anything we can do for you in any way. And then just finally, I'm going to send you, like I said, a follow-up email soon that contains a link to the PowerPoint presentation, the CE quiz, and most importantly, there's going to be a link to complete a very brief evaluation of this webinar. Completion of this evaluation is so critical to maintaining our funding and continuing to provide quality education and materials. So please, if you can just spare just a few minutes, it'll take about 2 minutes to just complete that evaluation so you can keep getting education like this coming to your computer for free. So just respond back to that evaluation if you get a chance. That would be really helpful. So with that, I will conclude today's webinar. So thank you again so much for joining us, and I hope you have a great day.